So I often get asked whether what the role is of the different kinase inhibitors in differentiated thyroid cancer and what is the sequence that we use. And I'll say at this point that there are two approved treatments for differentiated thyroid cancer. And at this point, we don't have any data about which one is necessarily better or even what sequence would actually be the best. We really do need additional data. So at this time, the decision for which one to use and in what order is often based on patient profile, sometimes on the dynamics of the disease, and we try to match the eligibility of the patient to what the trial was showing, and maybe we'll make the decisions based on that. But at this point, both lenvatinib or sorafenib can be used in the first-line setting, and then whatever one they get, they will get a different one in the second-line setting. So at the end of the day, 100% of my patients will end up being treated with both drugs, and until we actually have a clinical trial, we won't know which actual sequence is better. So an ongoing question is, when do we actually start therapy for radioactive iodine refractory thyroid cancer? And what we know is that we have specific criteria that were defined in both the decision and the SELECT trial that said that patients either had disease that was no longer taking up radioactive iodine or took up radioactive iodine and was progressing, or some patients who had just received multiple doses of radioactive iodine over their lifetime and there was concern about increasing toxicity with little effect. At this point, that is still the definition we would use, but then we also add the definition that we want to know that patients are progressing. With additional information from the decision trial of ad hoc analysis, we also get a sense that if patient's largest lesion is less than 1.5 centimeters, we might have an observation period before we would actually institute therapy in some patients because their disease may be more indolent. Many of those patients will progress in 3, 6, or 9 months and be started, but sometimes they can have an additional period of observation. We know that patients whose largest lesion is less than 1.5, they don't really get the benefit of sorafenib. Now, there are exceptions to that, of course, if they have miliary disease or bad placement of their lesions, but that can start to become a guideline maybe for what tumor burden is required before we would actually start therapy. So all of our patients will ultimately progress on either sorafenib or lenvatinib. And I think some of the information that came out of the symposium today is that stopping therapy at that point, especially if you don't have an additional therapy to offer, is not a good idea because many times the patients will continue to have a faster growth rate without a kinase inhibitor on board. So the first thing I would say is if there's no additional therapy available, we would recommend continuing therapy with a kinase inhibitor as long as it's well tolerated. In the States, we have also data that shows that the addition of everolimus to sorafenib now will actually give an additional 13.9 months of progression-free survival. We're ongoing designing a trial to do the same thing with lenvatinib to see whether at the time of progression adding in everolimus might also allow for an additional prolonged progression-free survival. So those are another strategy we might use. So we either might treat past progression with the same drug, we might actually add everolimus in as a combination therapy, and then there are additional drugs, for instance vemurafenib, which we know has activity in BRAF V600E positive tumors. That would be something I would do if a patient had that kind of disease in papillary thyroid cancer. Or then there's other agents that have shown activity in the phase 2 that could possibly be tried in a patient who has progression. So I've just given you some ideas of what we can do after a patient progresses, but what's really clear is that we need additional clinical trials. We need to know really what the sequencing should be. We need to know how everolimus can be incorporated into other treatment arms. And I also think that differentiated thyroid cancer is going to benefit from the new trials that are coming out that may have the combination of immunotherapies as well as multi-kinase therapies or possibly combination multi-kinase therapies. So I really do see this as the beginning of many, many treatments that are going to be available for this patient population, which is really good news because only about 3 years ago there was no FDA-approved drug that we would use. The only other FDA-approved drug being chemotherapy, which we know is not effective and highly toxic, so is basically not used. So we really are in a point of explosion of different therapies, which I believe have been successful in other settings, which will probably end up coming into the differentiated thyroid cancer arena.